Hello everyone, this is Dr. ATM Tanveer Hassan from Bangladesh. I welcome you all to the first AYR educational webinar of 2022 on cutting-edge developmental capillaroscopy in rheumatology. It is my great pleasure to be invited to chair today's session, and I hope that this is going to be a very useful primer for rheumatologists, rheumatology trainees, and those with special interest in rheumatology on capillaroscopy, which is a precious tool for the evaluation of Raynaud's phenomenon and also for the early diagnosis of scleroderma spectrum disorders. So without further delay, I would like now to introduce our distinguished speakers today, Professor Dr. Maurizio Cuttolo and Professor Dr. Vanessa Smith, both of whom are distinguished for their great contribution to capillaroscopy in the field of rheumatology. Dr. Maurizio Cuttolo, the former president of European Alliance of Associations for Rheumatology, is currently the professor of rheumatology and professor of internal medicine at University of Genova, Italy. He is also currently acting as the chairman of the classroom board of the Euler School of Rheumatology. And Dr. Vanessa Smith is the head of the clinics at Ghent University Hospital, Belgium, and also an associate professor of rheumatology of the same institution. She is a member of the steering committee of the European Commission Reference Network on Rare Connective Tissue and Complex Musculoskeletal Diseases Network. So it is my great pleasure to invite first Professor Dr. Maurizio Cuttolo to begin his speech. Over to you, Professor Dr. Cuttolo.
Thank you very much, Dr. Hassan, and to all the young rheumatologists from APLAR. It's in my heart, APLAR, you know, I have been met several times and was hosted during your session in the past, and I'm very, very happy to be invited. So thank you for the perfect organization, the invitation. Let me share the screen because the lesson will be full of information. I hope you will have an idea of what is today capillaroscopy, because we know very well that this is a big issue. And as mentioned, we hope that in the future, the people will use more and more this safe tool. Anyway, a short, very short history of modern capillaroscopy. The start in the 70s, so 50 years ago, with the earliest, can I say, expression, how it's possible to study in a safe way the microcirculation. And in particular, was clear from the beginning how important was the use of capillaroscopy, nightfall capillaroscopy, to investigate the early signals of some connective tissue disease, in particular systemic sclerosis. So, as we know, in 2013, the ACR and Euler introduced the capillaroscopic findings as important mandatory aspect in the guideline for the diagnosis of systemic sclerosis. But to learn, to understand the value of what we look with capillaroscopy, is important to spend some words how the disease at the beginning, the pathophysiology and molecular changes may explain the damage and what we see during the capillaroscopy. We know that the clinical symptom that show that something is wrong in the microcirculation in Raynaud phenomenon. And so from the Raynaud, then unfortunately the disease move up to such condition where you can see signals of strong dilation of the vessels and fibrosis of the tissues. But in the middle of this long story, sometimes it's really wrong, we must consider that all the pathophysiological and molecular basis of this advancement, it's possible to look from the very early steps what is going on in the microcirculation. And the early signals, morphological signals in microcirculation are associated with biomarkers in the serum, you know, very classical specific antibodies, but we have no time to discuss this. And up as the disease move, we arrive to the late pattern where you can see the strong expression of the fibrosis and the loss of capillaries. This is the advancement of the pathophysiology and the morphological changes associated that you can detect in a very easy way with the capillaroscope. And so we have the pattern, and Professor Smith will mention about the pattern. So the microvascular change, the microvascular damage is the beginning. And at the beginning, this is this silent from the clinical point of view, of course. Here starts from the normal association of Raynaud phenomenon, normal representation of the microvascular array, starts the pathophysiology, the damage of the vessels in patients that have stratification of risk for the start of the disease. And the earliest signals are dilation, a strong and persistent progressive dilation of the capillaries. But this is very, very early step, and is not yet possible to say that the patient is affected by any connective tissue disease. At that time, for the patient will progress in systemic sclerosis, the cells play a role in damaging the wall of the vessel. And so start the damage with abnormal dilation of the cells. If we get more than 40, 50% of capillaries with a diameter over 30 micrometers, this means that disease probably in a larger percentage of patients may become early, and so, for example, systemic sclerosis. In fact, the presence of giant capillaries will be explained by Professor Smith, is characterized by the dilation, the progressive dilation of the vessels up to the micro capillary, mega capillary, but we call them giant capillary. And giant capillary means also increased permeability, passage of red blood cells, axial, so microhemorrhages. And what we can see in the early pattern frequently is the presence of giant capillaries and microhemorrhages. So we are already in the beginning of the disease, and probably some symptoms are already present, as well as antibodies that play an important role in the damage of the wall of the capillaries. But as the immune response starts most seriously with production of large number of capillaries and also macrophages around the tissue, and the vessels are recruited, activated, we enter in the real active phase of the damage. And this is characterized by the EMA, sausage fingers, microhemorrhages from the morphological point of view. And you can see here it's changed from the normal condition. The pattern, you see giant capillary, loss of capillary, microhemorrhages, and this white color that is starting the fibrosis. This process of immune inflammatory reaction become then systemic, in short. And when becomes systemic, and even before start the late morphological pattern of capillaroscopy that is characterized by the progressive fibrosis in the patient, because all the cells around the vessel and the tissue are recruited as a microfibroblast, and they produce connective tissue and they produce fibrosis. So through different mechanisms like endothelial to mesenchymal cell transition, also adipocyte to mesenchymal cell transition, the fibroblast, resident fibroblast pericyte become fibrotic cells producing connective tissue. And so at the end, we have the late pattern that is a disaster for the patient, because that means advanced fibrosis and less capillaries. And we will see all the clinical complication will follow and will be related to this progressive loss of capillaries and increased fibrosis. So in few words, we have a normal condition, we have a very early damage with the start the enlargement of capillaries. This is something that associated with Raynaud we should always search, and then start the real pattern that Professor explained to you with the early, and then the active, and then the late, unfortunately, if the disease progressed to the late stages. So Night-fold capillaroscopy is related to the clinical aspect of the disease. Now it's clear that the progression of the different pattern means also progression of the disease. So we can, with such a very easy, safe tool, evaluate what is going on. In fact, as the disease progress, as the damage increase, as the tissues recruited with fibrosis, all the bodies involved, from localized dermal involvement, you have a systemic skin involvement, then internal organ involvement. So the disease becomes systemic sclerosis, systemic fibrosis. And it's important to see that this is one of the earliest pilot studies showing that there is an association between the severity of the pattern, and namely the late pattern, with the most advanced damage like peripheral vascular problems and even lung involvement. We know now that lung involvement is related even to this progressive lesion of the microvasculature and the increasing fibrosis in the lung. So this is another early study that we evaluated the progression of the disease over 5 years. And you can see that over the time, as the pattern become more and more severe, even the involvement of different organ tissue like the lung, maybe also the gastroenteric system, or the kidney, or the skin progress, up to this study that observed in a 12-year follow-up, from the early pattern that progressed in 67 patients in correlation with the progressive involvement of the organs. And so you can see over the years, from 0 to 12 months, has the involvement of different organ and tissues related to the different pattern become a reality. So a strong correlation, significant correlation between the patient and the large number over 12 years, about 40% become active and then late. And so late means really systemic sclerosis with all related problems. Well, this is what we know. And the conclusion is this capillaroscopy followed very well the progression of the disease. But let me now tell you something about the correlation in other studies. For example, in this study, evaluate in 3 years the progression again of the damage and observe how again the pattern, this is a large study, again the active and late pattern monitorize the severity of the clinical involvement in such patients. So this is really even well correlated with the earliest classification by Marek in the 70s that showed how the advanced pattern is the most important aspect. But now we have the possibility to follow from the beginning the disease with the early. So let me show, for example, how progress the damage of the skin, for example, in our patient, in correlation with the signal, the morphological signal of the damage. We know that giant capillaries, microhemorrhages means progression up to the advanced step, as I mentioned, with loss of capillaries, fibrosis. And almost all patients present at that time signal of tissue ischemia related to the fibrosis and from the loss of capillary. This is an important aspect because in the very large studies involving 14 countries and 623 patients, we were able to show that just the capillaroscopic analysis of the one finger, the middle finger of dominant hand, when we have evaluated 120 parameters, just the loss of capillaries is the most important parameter that may predict the progression of the disease. And following the unvariated analysis, you can see with Rokovic showing in a very significant manner that the loss of capillaries is characterized by, at the same time, signal of clinical involvement, in this case, digital ulcers. Even was produced prognostic indices for digital trophic lesion with a very good sensitivity and specificity. So we can base it on the observation of the changes on capillaroscopy to predict over 6-12 months the progression skin lesions. And here another study evaluating a large number, 2,754 patients, and looking at the progression, the different pattern, you can see also, especially in the active late pattern, how the most important organ are progressively involved over the years. So there is a clear evidence that at least for the skin damage, there is a correlation between the damage we can observe with the capillaroscopy and the progression of the damage itself. But what about the lung? Here, it's less possible, of course, to visualize clinically the damage, because on the skin, it's easy to see the Raynaud, to see the ulcer, to see the puffy finger, but the lung, what happened? So in the lung, we have almost the same problem. So in the lung, we can also associate the progression of the damage with the pulmonary arterial hypertension and even with the interstitial lung disease. That is one of the most, we can say, progressive and really irreversible change that will decide the exit of the disease in our patients. So from the beginning, already in 2009, was observed that if you look at the patients with systemic sclerosis without pulmonary hypertension, you have such a number, 6 number of capillary per millimeter. If you have a systemic sclerosis with pulmonary hypertension, the number dropped down due to the fibrosis and the loss of capillaries. So this was one of the earliest observation that there is a clear association that you can detect very easily at the level of the capillaries, the progression, the loss of capillaries, and of course, the progression of the fibrosis. This is another very important systemic sclerosis that shows that pulmonary arterial hypertension in systemic sclerosis is associated in several studies with the progressive capillary loss and progressive progression of the pattern. So up to the active and late pattern. And even cross-sectional studies was again inversely associated the capillary density with the presence of severe pattern, once again, the advances. So even at the level of density and even at the level of the morphology, so quantitative and qualitative change were associated with the progression of the pulmonary damage as normally detected. This is an important point because it's clear that the involvement of lung in systemic sclerosis is something that happened, unfortunately. And even if we look at interstitial lung disease with a systemic review, here again, cross-sectional study, the presence of the association of the loss of capillary was inversely associated with the severity of the pulmonary involvement. It was associated, the active pattern, with the presence of all the signals of the disease with a significant association in cross-sectional studies, but also in longitudinal studies. So you can see the significance and the progression of the capillary losses that I told you is the most important parameter to evaluate when you want to evaluate the follow-up of the disease, but also the baseline, the severity of the disease, as well as, of course, the morphological progression of the pattern are significantly associated with the progression of the fibrosis in the lung. So we have several evidence. This is a very recent study just published last month. And again, this study found a reduced baseline test of lung functionality associated with a reduced number of capillaries, with a very interesting, significant, you see all the presence of the most important parameter, but specifically the number of capillary So the quantitative evaluation of the capillaries, the scoring of the capillaries is associated with the severity of the disease. And even, of course, the reduced DCLCO was associated with advanced pattern. Fortunately, this pattern, the late pattern, is observed less and less when the patient are identified and treated from the beginning. So evaluated microcirculation is quite complex and is not limited to the morphology, even if today we can score the number of capillary, but also to the functional evaluation of microcirculation. So the combination of the morphology with the reduced peripheral blood flow is something that lets us to get a real window on the situation. And so it's important to combine, if possible, both analyses. The tools to evaluate the nail-fold microvasculature, even if I focused my presentation on capillaroscopy, the title of this lecture, it's different because not in any center is possible to have not very expensive, but in any case, a little expensive tools like capillaroscope, the video capillaroscope. You can use also the dermatoscope or the USB, very cheap USB, but there are some limitations that I will tell you. In any case, what we must be able to see is the progression from the normal, early, active, and late. If you cannot detect with USB, this kind is nothing to do. Leave it. But if you compare the dermatoscope and the capillaroscopy, for example, searching nail-fold giant capillaries in the skin versus the nail-fold, you can see that sometimes you can find a correlation. For example, the spiders you can see for the angiogenesis with the dermatoscope is what we call the angiogenesis, the bushy capillaries in the late pattern. So it's possible to find some association, and even if you put the dermoscope and the USB microscope on the nail fold of your patient, you can detect. But it's important to be able to detect such changes. So it's clear that the evaluation must be evaluated with a number. Now is available also an automated software to count the capillary number. And this is really important because it's based on a very sophisticated system of evaluation of the capillaries, giving to you in an automatic manner the number of capillary over a 1 linear millimeter. This is really important when you want to make, for example, the studies between centers. And so you want a reader that is the machine and not you. At least on the number of capillary, you see all the different evaluation were utilized to obtain at the end a system that may count the number of capillaries in a normal pattern, the reduced capillary in the early pattern, the much more reduced capillary inactive, and the disaster in the late pattern with very few capillaries, as you can see here. So the system may give such kind of evaluation, and when was tested the reliability versus the manual evaluation, the reliability was very good in a large study with 4 independent observers. So what is important in any case is to score the number of capillaries, either manual or with much more sophisticated system is important to evaluate. But there is the progression also, a continuous progression in order to evaluate the structure, the number of capillaries, and is a photoacoustic optical imaging. This is a very advanced system that give you, when you compare on the top, you see with capillaroscopy, dermoscopy, the array. Of course, there are some limitations, is at the beginning, the evaluation, but you can get, for example, in the last picture on the right bottom, as you can see, the increase of the white of the capillaries or the loss of capillaries in the middle, on the right side middle picture, you can see the loss of capillaries. Of course, this gives a non-invasive, high-resolution, 3-dimensional visualization of neocapillaries, but up to now is not absolutely for the clinical purposes, just basic research. Here I promise to show the difference with different systems to evaluate the morphology of capillaries with the stereo microscopy, the dermatoscopy, the just photoacoustic system with the most advanced RSOM. And you can see versus the naval capillaries. At the end of the story, if you look different parameters, so, and you mix all together, like the possibility to store the image, to have a dedicated software, and especially to have automatic or semi-automatic system counting, and especially that you can bring to your patient, on the bed of your patient, the capillaroscope, or easy to evaluate in the room. You see that at the end of the story, the naval capillaroscopy today still the gold standard for the evaluation, morphological evaluation of the microcirculation. But if we want to evaluate the finger microcirculation in our patient, because it's important, as I mentioned, to have a morphological, but also a functional idea of the status of the microcirculation, because this is the basis then for the clinical complication like ulcers, lung involvement, and so on. The oldest system in infrared thermography that is still very easy and non-invasive and cheap method, but it's absolutely difficult to quantify the intensity in a reliable manner, the intensity of the blood flow changes from the Raynaud to the final systemic sclerosis advanced stages. This laser speckle contrast analysis is the best method actually available. Of course, is very expensive, but in the center of referee, and in each country, maybe some very advanced center in systemic sclerosis for the study of systemic sclerosis should have it. This is not only a visual evidence, but evaluate in any area of your body you want, especially hands, face, in every region of interest, the intensity of blood flow. So this is very important aspect, because when you mix both the morphology and this kind of in vivo evaluation of blood flow, you get an important information on the status. Other systems like fluorescent optical imaging that include the injection of fluorescent substance, it's also been used, but the limit is that you need to do the intravenous fluorophore, and so it's a bit invasive. What is going very well showing the intensity of the blood flow in the single finger, but also at the level of the navel, is the power Doppler ultrasound. Here you can see how it's possible to evidentiate a single capillaries in the finger. This is the finger of a patient, and you can get also some number regarding the intensity of blood flow. So if you combine the power Doppler ultrasound with the morphology of capillaroscopy, here you can have very, very important information on the blood flow. Of course, you need some device with 22 megahertz to evaluate this, but many centers have a power Doppler machine, center of rheumatology. Here again, if you want to compare the different devices for the analysis of peripheral blood flow, and this is part of the big review we have just published in Nature Review Rheumatology, you can see that the different tools, the laser Doppler, the laser Doppler single beam are important, but probably the most fast and reliable and scoring system, easy to be scored, of the LASCA, laser Doppler speckle analysis, and the power Doppler ultrasound. So let me show just now very fast the different naval capillaroscopy pattern that you can observe in different rheumatic disease. This is another interesting area, because it's increasing the interest to use capillaroscopy in other disease rather than systemic sclerosis. Now we have published, and many researchers published on systemic lupus, psoriatic arthritis, dermatomyositis, mixed connective tissue disease, is that the field is open even to you. We are open to cooperation with you if you like, if you want to start some studies in different diseases, looking at the literature before and starting a project. This pattern that is called the scleroderma-like pattern is very fascinating pattern because you can certainly hear all the different changes that the capillaries may be induced by immune inflammatory reaction. You can see giant, you can see macrohemorrhages, you can see angiogenesis, you can see loss of capillaries. So altogether, the most important changes. This may be observed in dermatomyositis and in mixed connective disease, but even in antiphospholipid disease is classical, such comb-like pattern. You see the parallel hemorrhages, the microthrombi in patients with antiphospholipid syndrome. And finally, it's important that these last slides combine the morphology and functional analysis, what you can get regarding the severity of disease, but just not systemic sclerosis. Of course, in systemic sclerosis, you can see you may have the scoring of the intensity of blood flow and the number of capillaries. In this study, you can see over the time, 2012, 13, 14, a patient treated with therapy increased. You see the yellow increase means increase the peripheral circulation, and you see the number of capillaries increased from 7 to 9 capillaries in milia. So billion of capillaries, that means improvement. But also in psoriatic arthritis, if you look at the lesion and the number of angiogenesis 4 millimeters square in this case, you can see the LASCA analysis, and you can see on the bottom at the beginning of the therapy and the right with the clinical resolution, the decrease also the angiogenesis. So we can say in conclusion that capillaroscopy, in particular nightfold capillaroscopy, is considered today the safest, cheapest, reliable, and direct tool because it's just a camera to investigate the macrovasculatory status in rheumatology, as well together with other systems. But the interest is now growing in the field of internal medicine. Also, we saw yesterday some study in acromegalia and so on, so on, so on. And here, final image, just to give you the interest for capillaroscopy in the last 15 years, look at the growth. It's really impressive. Look the growth up to last years. So thank you very much. And now I would like to introduce Professor Smith that will present how to very easily start to use capillaroscopy for early diagnosis. Please, Professor Smith, here a view of our co-workers in my department. Thank you very much.
Good morning to all. Can you see my screen?
Yes.
After this wonderful lecture in which we had a perfect overview of all the tools to evaluate the microcirculation, the history of the capillaroscopy, the links with clinics, now it's time for you to start working and to pay attention, because after the next 15 minutes, you will be able to evaluate a capillaroscopic image. And then afterwards on the website, you can take a quiz. I would like to start this lecture with a view of the harbor of Genoa.
You should click on the first slide, please.
Do you see something?
We saw all the slides together. You should make in show.
It's in show modus. I will restart.
Saw all.
It's very strange because I'm in.
Okay.
Do you see the first slide now?
In the middle of the others, sorry. You should click the full visualization on the bar, down on your bar. The full.
It's on the full visualization. What do you see now?
We see the first slide, but not an entire presentation. Only part.
I will restart. This is very strange. I will stop the share and restart.
Sharing again.
No more.
Yes, right. And then share the PowerPoint slideshow.
Can you see the first slide?
Perfect. Thank you.
Thank you so much. So after we had a wonderful overview of history of microcirculation and link with clinics, I would like to start with this first slide showing the harbor of Genoa. And this is also the harbor of the origin of capillaroscopy, where Professor Cutolo has his school on microcirculation and rare connective tissue diseases. So as we heard in the previous lecture, the main role of capillaroscopy is to evaluate patients with the Raynaud's phenomenon. Why? Well, we know that patients with Raynaud's phenomenon can get connective tissue diseases and mostly systemic sclerosis. And capillaroscopy in combination with antibodies, systemic sclerosis specific antibodies, help us predict which patient with just a Raynaud's phenomenon will futurely develop systemic sclerosis and which patient not. In a nutshell, and I would like you to read this paper this weekend before you take the quiz. In a nutshell, if you have Raynaud's phenomenon and no scleroderma pattern on capillaroscopy and no systemic sclerosis specific antibodies, then your chance to get systemic sclerosis is very low, only 1.8% over 20 years. And this algorithm has a very high negative predictive value. So this means that if you say to this patient with a Raynaud's phenomenon and no scleroderma pattern and no systemic sclerosis specific antibody, that this patient will not get systemic sclerosis, that you're correct in the majority of cases, more specifically 93%. Conversely, this algorithm described in the paper of Koenig also teaches to us that if you have Raynaud's phenomenon, but a scleroderma pattern on capillaroscopy combined with systemic sclerosis specific antibodies, that your chance is very high to get systemic sclerosis. And this is why we need to know what scleroderma patterns are and what not. The following capillaroscopic characteristics are per consensus being evaluated by the APLAR study group on microcirculation in rheumatic diseases: the density, dimensions, abnormal morphology, and hemorrhages. Based on the combinations of these capillaroscopic characteristics, an image can be classified as a scleroderma pattern, as you can see here, or a category 2, or a non-scleroderma pattern. But the vast variety of non-specific abnormalities are sometimes challenging for the non-expert capillaroscopist. So what we will teach you today is a fast-track algorithm to, when you see an image, within 1 minute, classify the image yourself as a scleroderma pattern or as a non-scleroderma pattern, because we know how important scleroderma patterns are for the prediction of development of systemic sclerosis, and how happy we are if a patient has a non-scleroderma pattern, because then we know from the paper of Koenig that the chance to get systemic sclerosis is very low. So let us teach to you, and let us go over some images together on how to simple and fast categorize an image as a scleroderma pattern or as a non-scleroderma pattern. I suggest you take a picture of this PowerPoint slide, and in the next images, we will show you capillaroscopic pictures, and you yourself can think whether the next pictures will be scleroderma patterns or not, and I will, of course, also go over them with you. The first rule, we only have to remember 3 rules in the fast track algorithm. The first rule is, if your density is 7 or more, and I will learn you how to count, and if you have no giants, then your image belongs to a category 1 or a non-scleroderma pattern, the safe patterns. Rule number 2 is, if you have giants, or if you have the combination of an extremely low density, 3 or less, with abnormal shapes, neoangiogenicis, then your image is a scleroderma pattern. If your image doesn't belong to rule number 1 or rule number 2, then it's automatically belonging to rule number 3. And this says that in all other cases, your image automatically is classified as a category 1 or a non-scleroderma pattern, a safe pattern. This is a fast track algorithm. In next slides, I will first separately discuss capillaroscopic characteristics. I will teach you what is density, what is dimension, what is abnormal shapes. And then I will apply the fast track algorithm to an image with you. The first capillaroscopic characteristic is density. In a nutshell, because we don't have so much time now, but a normal density is 7 or more. And you can find some literature here, which I would advise you to read also if you have time. This is consensus papers by the Euler Study Group on Microcirculation in Rheumatic Diseases. If your density is lowered alone, then you call it a non-specific abnormality. And as was nicely said in last lecture by Professor Coutinho, in the scleroderma patterns, you have progressive loss. So in an early pattern, you still have a normal density, but in a late pattern, you have an extremely lower density. But this is not within the remit of this lecture to be able to produce this table. In the remit of this lecture is to learn when you see a capillaroscopic image, as you can see here, to classify it as a fishy or scleroderma pattern, because if you have that in a patient with Raynaud's phenomenon, you must watch out, or a non-scleroderma pattern. So let us start to apply the fast track algorithm to our images. This is a first image. I count the density with you. The density you always count in the capillaries that are closest to the nail. Here you see the nail. Here you see the finger. So I count the tips that are closest to my nail. We call it the distal row. Here I count 1, 2, 3, 4, 5, 6, 7, 8. If you see an image like this in a patient, you don't have to look where is this in this table. No, you take the fast track algorithm. So let us see to which rule this belongs. Well, my density is more than 7 and I have no giants. So my image is automatically classified here. It's a non-scleroderma pattern. And we know from Koenig, if you have a non-scleroderma pattern and no systemic sclerosis-specific antibodies, that your chance is very low to get systemic sclerosis over the long time. Let's look at this image. Here I count 1, 2, 3, 4, 5, 6 capillaries. Again, it's not within the remit of this lecture to know this table, but it's in the remit of this lecture to apply the fast track algorithm. My density, is it 7 or more? No, it's 6. Okay, I go to the second rule. Do I have giants or do I have an extremely lower density, 3 or less? No. So my image also doesn't apply to rule number 2. Hence, we know we automatically go to rule number 3, and this classifies your image automatically as a category 1 or a non-scleroderma pattern. Just some more explanation to us now here. This is a non-specific abnormality. It's a solitary change in density. So again, this is a non-scleroderma pattern. If you have this in a patient with Raynaud's phenomenon and no systemic sclerosis-specific antibodies, then you know that the chance to get systemic sclerosis is low, based on the paper of Koenig. The second capillaroscopic characteristic which we evaluate is dimension. Again, we don't have a lot of time to go over the exhaustive literature on this, but we will learn to classify based on the fast track algorithm. But in a nutshell, a normal dimension is less than 20 micrometers. The dimension measured apically can also be changed. Dilation, small dilation between 20 up to 50 is called a non-specific abnormality. And in the scleroderma patterns, you always have giants, which means that you have an apical diameter of more than 50 micrometers. Giants are normal shaped capillaries, and normal shapes are hairpin shapes, or tortuous shapes. This means that your tip of your capillary is still convex, but the limes are undulated, or a crossing. If you have one of these normal shapes and an apical diameter of more than 50, then you speak of giants. So let us make some exercises together. Think for yourself, in this image, is your density 7 or more? And do I not have giants? Well, I think yes. Let us count together. I count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 capillaries. No giants, so this is a category 1. It's a non-scleroderma pattern. And think for yourself in this image. Is your density more than 7? No, it's not more than 7. It's 1, 2, 3, 4, 5. Okay, we go to rule number 2. Do I have giants? Yes, I have giants. As we discussed earlier, giants are normal shapes with an apical diameter of more than 50. Well, you see giant here and you see giant here. So according to the fast track algorithm, when you see this image, you can readily classify it as a category 2 or a scleroderma pattern. Shortly, as Professor Couture told you, there's 3 major patterns: an early, an active, and a late pattern. How to easily know what patterns you have? Well, the early pattern consists of giants, but you still have a normal density. In the active patterns, you have a lower density combined with giants and hemorrhages. And in the late pattern, you don't have giants anymore, but you have abnormal shapes, which you will learn in a minute, and extremely lower density, 3 or less. Let us continue to make exercises. Is this a scleroderma pattern or not? This is what you need to know after this lecture, because this is a first training lecture in which we learn to categorize images as scleroderma patterns or not. Well, in the beginning, when I was executing capillaroscopy, I was worried by this image because you see here a changing dimension. But if you apply the fast track algorithm, you see there's 1, 2, 3, 4, 5, 6, 7, 8 capillaries. The density is 7 or more and there's no giants. We classify this as a non-scleroderma pattern. Of course, and of note, as we saw in the previous lecture, when you have some non-specific abnormalities in a patient with Raynaud, you may want to see this patient again on a redo capillaroscopy if you have a combination of a lot of non-specific abnormalities. But again, this is not within the remit of this lecture. After this lecture, you need to be able to classify this image as a non-scleroderma pattern. This brings us to the third capillaroscopic characteristic, shape, morphology. What is a normal morphology? Normal morphology is a hairpin shape, a tortuous shape, as I said, the limes bend, but they do not cross, or a crossing shape. The limes cross once or twice of your capillary. This is a normal shape on the condition that your tip is convex. And why did the APLAR study group introduce convexness of the tip as a characteristic of a normal shape? Well, to have reliability when you execute research and you want to have reliable interpretation of a characteristic. We saw that if you introduce convexity of the tip as a condition to be normal, that you can have reliability in between razors of different centers. Let us make an exercise on this. In this image, do you think this is a normal shape or not? No, it's not a normal shape. It's not hairpin. It's not torches and it's not crossed once or twice. This is an abnormal shape. So let us apply the fast track algorithm. Is my density 7 or more? No, it's not. It's 3 or less, because in this image, I only see 2 capillaries. So this image applies to rule number 2. It's a category 2. It's a scleroderma pattern. And if you go more into detail, and if we then go to our table, we see it's a late scleroderma pattern. A late scleroderma pattern is characterized by an extremely lower density. You only have 3 capillaries. You only have 2 capillaries, and they are abnormal shape. Let us apply the fast track algorithm to this image. In this image, we count 1, 2, 3, 4, 5, 6 capillaries. And this is an image I was worried about in the beginning when I executed capillaries, because I saw here an abnormal shape. The tip is not convex. Well, with the fast track algorithm, you can safely classify this image as a category 1 or a non-scleroderma pattern. Let us check. We have 6 capillaries.
Sorry, Vanessa, look the time.
Yes, I started at 45. So I think I should have 2 more minutes. I'll be finished then. Is that okay?
We have a discussion there. Yes, okay.
Thank you. So if you look at this image, it does not belong to rule number 1 because your density is 6. It does not belong to rule number 2 because you don't have giants and you don't have 3 capillaries or less. You have 6 capillaries. It belongs to rule number 3, and this automatically classifies our image as a category 1 or a non-scleroderma pattern. And this brings us to the last capillaroscopic characteristic, hemorrhages. Hemorrhages is not incorporated in the fast track algorithm. Why? Well, because hemorrhages can occur in healthy controls, in you and me, as you can see on the left, or can occur in connective tissue diseases. And this, if you would apply on this image a fast track algorithm, you would readily see it's a scleroderma pattern because there's giants. In the paper of Cabasakal, you can see that hemorrhages can occur in 5% of healthy control if they're punctate. If they're large and confluent, they can never occur in healthy controls, but they can occur in connective tissue diseases. This image is a type of image that you will see in the quiz, but it's not the image of the quiz, of course. I would like you to take your picture, which you have taken with your iPhone, with the fast track algorithm, and apply it yourself to this image. And then I would like you to tell me, you can tell me in the chat or you can tell me out loud, which of the following options is not correct. There's only one wrong reply in this options. Let's take a minute to do this and then you can tell me. Okay, I hope you have made up for yourself your decision if this is a scleroderma pattern or not. Well, let me count the capillaries. I count 1, 2, 3, 4, 5, 6 capillaries. So this is correct. It shows 6 capillaries. I count 1 abnormal shape, 2 abnormal shapes, 3 abnormal shapes. So this is also correct. I see a hemorrhage. This is also correct. Is this image a scleroderma pattern according to the fast track? I don't think so. Let us see what rule it applies to. We have 6 capillaries, so it doesn't apply to rule number 1. Does it apply to rule number 2? Do I have giants, or do I have an extremely lowered number of capillaries? No. So it applies to rule number 3, and this says to us that automatically it's a non-scleroderma pattern. You will have a common-like quiz, but also with interpretation on the website after this meeting. Thank you so much for your attention. We are ready to take any questions.
Thank you, Professor Dr. Maurizio Cucciolo and Professor Dr. Vanessa Smith, for your wonderful and enlightening lectures. Now moving on to the exciting question and answer sessions. So we have already so far 8 questions asked by different participants. So I would like to ask the questions one by one. So one of the participants asked, does increase in magnification of nail-fold capillaroscopy more than 200x, 200 times, hamper the findings? So can you please answer?
I think it can hamper the findings. We had no time to go extensively over the consensus paper by the APLAR study group. And of note, as Professor Cucciolo said, you're all invited to join the APLAR study group. Just write an email and I will add you on the list. But per standard, we use a 200 magnification. If you use a higher magnification, then the image jumps up to you, and even normal capillaries can look like giants. So if you use a higher magnification, we don't really have consensus standardization on that. I hope that replies to the question.
Thank you, Professor Dr. Smith. My next question, how often should we monitor the progression or response to treatment by nail-fold video capillaroscopy?
This is a very frequent question. And to monitor the therapies should be at least every 6 months, because earlier is not sense, because before you have some change in capillary, it takes time, from 6 to 12 months. But in particular condition, when you have a very intensive therapy, you can already observe some changes after 6 months. So the suggestion is to see every 6 months your patient and compare the score, the number of capillaries. Thank you.
Thank you, Professor Cucciolo. There is another very long question. Let me summarize it. One participant asked whether when a patient visits 2 to 3 years after the onset of systemic sclerosis, can NVC guide the NVC findings, guide us whether or not to start immunosuppressive therapy for cutaneous involvement of the disease? Is it, I mean, if the nail-fold capillaroscopic findings are really advanced, is it going to say that the treatment is no longer, the patient is no longer, you know, worthy of getting any treatment because it's already advanced, or whether it cannot guide?
It's a very nice question. But first of all, I would like to say, if you see patients with systemic sclerosis in expert centers, you need to see them yearly and do their whole monitoring with evaluation, whether they will develop interstitial lung disease or pulmonary hypertension. Anyways, you should do that every year in the expert center, and in between, the patient can be seen with a local rheumatologist. This is beside the question, but I wouldn't wait for 3 years to see a patient. That's why I said it. Secondly, as I wrote in the chat to an earlier question, in the near future in the rheumatology, we will see very nice publication of 8 centers. Professor Cucciolo and I took part, in which we evaluate baseline capillaroscopy and looked whether those patients developed in 2 years afterwards novel severe organ involvement, skin progression, lung progression, mortality, etc. Baseline active or late pattern is severely associated with future development of novel severe organ involvement. So it's always a red flag. Also, patients who have a lower density, as was already very nicely shown in the first lecture today, has been attested to develop in the future novel severe organ involvement. So also this is a red flag. I hope that replies to the question.
Thank you, Dr. Smith. The next question. Are there any study, is there any study evaluating impact of skin pigmentation on NFC findings?
Sorry,
There's
can
a
you
very
repeat?
nice study by Andrade who evaluated in Brazil 800 healthy controls and also skin pigmented controls. And this study showed that if you look at nail folds, some nail folds may not be visible, but if you look at them and say, and don't take them into consideration, but if you take the nail folds into consideration that are visible, that you have the same findings as in other Caucasian population.
Thanks a
Would you
lot.
like to reply to that also, Professor Coutelot?
It's okay, it's okay.
Thank you.
The next question, it is, do we need to do NFC in every patient with connective tissue disease without Raynaud phenomenon?
I can certainly reply, but I don't want to steal your reply. So please go ahead, Professor Coutelot.
No, you can do. You can do.
Yes, it's a very nice question. So what we have taught, but we had a compressed hour today, is that the main role is in patients with Raynaud's phenomenon. So all patients with Raynaud's phenomenon we must do. But the question that is posed now is a different question. Can I also check it in connective tissue diseases without Raynaud's phenomenon? Of course you can, because if you will have a patient with muscle weakness and you perform capillaroscopy and you see a scleroderma-like pattern, then you have a diagnosis of an inflammatory myopathy. And it can also help us in idiopathic pulmonary fibrosis with autoimmune features. Because if a pulmonologist phones you and he says, I have a patient with interstitial fibrosis and some skin rash, and you perform a capillaroscopy in this patient who doesn't have Raynaud's phenomenon, it can also show a scleroderma-like pattern, and it can point in the direction of an inflammatory myopathy. So yes, you can also perform capillaroscopy in connective tissue diseases.
However, the issue is
interstitial lung disease in helping the pulmonologist decide if it's an autoimmune related lung disease or not.
However, the issue is that normally when you have the Raynaud phenomenon, even if you don't have another signal of a possible immune response, I mean, for example, the presence of general anti-nuclear antibodies, in any case of Raynaud phenomenon, it's important to look at the status of the microcirculation. Why? Because in almost 20% of cases, especially young female, the progression of primary Raynaud phenomenon, secondary phenomenon is statistically possible. And so you lose, if you don't do regularly the capillaroscopy, lose this window of opportunity to detect at the beginning, just when the disease is starting with the damage of vessels, and around there are antibodies. There are antibodies that we already are not able to detect because the concentration is too low, for example, or are very specific antibodies that are not our standard antibodies. So we lose the possibility to think about what about to start or not the therapy if this patient with Raynaud phenomenon, antibodies, and probably the real systemic sclerosis very early or early. At that time, we suggest to consider the presence of antibodies the beginning of the disease. So it's the time to start immunosuppressive therapy. And as earlier you start, as the better you can reduce the progression. Because as we discussed, the fibrosis is the consequence of the immune inflammatory reaction around the vessel with recruitment of normal cells like endothelial cells as a fibrocyte. So if you block at the beginning the pathophysiology, for example, blocking with rituximab the high production of antibodies, you can get very good result with early intervention. So in few words, Raynaud phenomenon is fundamental. The absence of Raynaud phenomenon is mentioned before, but the presence of signals serological clinical of a connective tissue disease, like maybe dermatomyositis, as mentioned before, it's clearly, as the majority of connective tissue disease, is clearly to be investigated because the involvement of microcirculation is present in all connective tissue disease, even not related to the immune response in terms of antibodies, like in psoriasis. In psoriasis, we observe angiogenesis in every site of the disease. In psoriatic arthritis, you look at synovial tissue, you see angiogenesis, but you don't have an autoantibody. You have an innate immunity, while IL-17, the major driver of the disease, but you have morphological changes. So if you don't have Raynaud, if you don't have the presence of autoantibodies, you must, as mentioned, search for the capillaroscopy, because you will observe during the time very interesting changes.
Thank you, Dr. Cutolo, for your elaborate answer. So there is, because of time constraint, I can take only 2 more questions. So one participant asked, for beginners with no experience, which specific capillaroscope do you suggest to use?
This is a very practical question. So as I mentioned, when I compare the different tools, if you look at the cost, the most cheap is the USD. There are USD even $30, $40 or 50 euros. But the problem is, you can get even with the USB microscope the presence or not of giant, but that's all. You can only say this patient with Raynaud has abnormality and probably is a scleroderma pattern because I see some giant. This is the beginning of the disease, of course. When you have advanced disease, you observe loss of capillary, and even USB is able. But depends what you want to do over the time. You have to count. It's not possible with USB or other dermatoscope system. You won't have a comparison of picture. It's not possible if you don't connect USB to the camera, and then you need to an application to store the image to compare. So there are limitations on the follow-up. So we suggest absolutely to use the pocket ball, dermatoscope, and USB when you want to have the first screen without much sophisticated evaluation. Just to give a look. Yes, there are giants. Yes, I must look better with maybe video capillaroscope, stereoscope, but you can use for the early diagnosis, not for all the criteria Professor Smith showed fulfilling with the USB, because you cannot count very well. Of course, you cannot have the millimeters and so on, but just for the giant, that is the most important early dilation, early symptoms, you can use this just for first screening.
Thank you, Dr. Cutolo. Then the last question, is there any difference between twisted loops and mindering capillaries?
Please.
It's a very nice question. It's a very nice question, and we did not have a lot of time today because normally we take 1 hour just to explain the standardization. There is a lot of literature concerning morphology, and the problem with different literature from different parts of the world is that sometimes there were inconsistent definition. A twisted loop may mean something different in Germany than a twisted loop may mean in Brazil. In short, a meandering loop, when you look in the initial landmark paper of Andrade last century, a meandering loop is a loop in which all parts of the capillary, the afferent, the apical, and the efferent, cross upon itself several times. We have stepped down from using individual definitions. We have grouped them into normal capillaries, which you also saw on the table, and abnormal. Why? Because there were so many terminologies, bushy, meandering, arborization. So this is why with the APLAR study group, we decided to make a consensus definition of a normal shape. And a normal shape in the first study was defined as a hairpin shape or a shape in which there was tortuosity, the lines bend but do not cross, or thirdly, a shape in which the lines cross once or twice. And we made in the first study this as a normal shape, and we saw that the inter-rater reliability was not high enough. We want an inter-rater reliability of 0.8, 0.9. So Professor Coutelot made a second study where he added that a normal shape should be hairpin or tortuous, which means that the line bent, or crossed once or twice, but also the tip must be convex. And if we applied that definition and we let several attendees classify individual capillaries as normal or not normal, then we had a great inter-rater reliability. And this is why we have stepped down in studies from saying meandering or bushy or ramification. No, in research studies, we classify as normal shape or not normal shape. But having said this, twisted means that the limes curl several times. Meandering means that the limes cross several times, also the apical line. But we have stepped down from using these individual definitions because we know that they mean different things in different countries. So we only use normal or abnormal shapes. I hope that replies to the question.
Thank you, Dr. Smith, for the wonderful and elaborate answer. So with this, I'm going to conclude the question and answer session, and I would like to apologize to them whom there are questions of whom we could not ask due to time constraint, but most of them are similar to the ones which already have been answered or have been already touched in the lectures. So now I'm going to move on to the next section. Stephen? So the exciting AYR Blackboard session. So here we actually arrange two exciting and challenging MCQ format questions for the participants to answer. You can simply click on the address given here, www.aplar.org, and then click on the AYR section and then move on to the AYR Blackboard. And then you will see the questions, and then you can answer it based on your knowledge and what you have grasped from this lecture, and then you can check the questions, the answers against those already provided in the website and get your knowledge tested. I think that will be a very pleasant experience for all of you. So now I'm going to move on to another exciting session. So it's my great pleasure to introduce you to the brand new APLAR educational activity session organized by the APLAR Education Academy. It is actually the APLAR Grand Round, which is supposed to take place bi-monthly, and it will consist of a case presentation of an interesting case by a bright AYR member, and this will be further reviewed by another esteemed guest faculty. For example, the first one will roll out on the 19th of this month. The theme will be clinical immunology, and it's my pleasure to introduce you to the first presenter from Hong Kong. She is Dr. Helen Sang, a very bright young rheumatologist from Hong Kong, and it will be reviewed by Professor Gregory Cheng, who will act as the guest faculty, and he is from Macau University of Science and Technology, and other sessions will follow accordingly as shown in this table bi-monthly. And actually this will be held on the third Saturday of the month when it is to be organized. Yeah. So I actually am welcome to all of the participants to the very first APLAR Grand Round session, which is to be held on the 19th of this month. So here are the participants. The case presenter. Professor Gregory Cheng will review the case, and Dr. Priscilla Wong, the AYR chairperson, will moderate. And this is the you can go to the APLAR website and then find this poster, and then click on the link given in the poster, or scan the QR code to get registered. And I will earnestly request everyone to participate after registration and make this program really, really successful. So now I would like to express my heartiest thanks to Professor Dr. Baruzia Kutolo, the first speaker, and Professor Dr. Vanessa Smith, the second speaker, for the wonderful, brilliant, and very elaborate lectures that made many things very easy, I think, for the all the participants. And now, may I request all of the participants to fill up the post-event online feedback form, which is, which you can go to by scanning the QR code shown here, or you can follow the link which will be shown after the end of this webinar. This will really help you to know your valuable input regarding how we can improve our next webinars. So we are actually closed the session, and I actually would like to invite you to the upcoming event, which is supposed to take place tomorrow. It's on the 6th of February. It is about rheumatoid arthritis patient awareness. It will be our pleasure to have you in this program. So with this, I would like to conclude this session, and it was a wonderful session, I would say. And thank you everyone for your active, interactive participation. Have a nice day. Thank you.
Have a nice day. Thank you so much. Bye-bye.
Thank you to you and to young APLAR.
Thank you. Bye-bye. Bye. Thank you.
Thank you to you.
Thank you so much.